Have you ever thought about what actually happens the second you take a medication? I mean, a massive, microscopic tug of war literally kicks off right inside your body. Welcome to this explainer, where we're going to unravel the highly calculated chemical negotiation that's happening right under our skin every single day.
We've got a great roadmap for our journey today. We'll start with the basic science, figure out how drugs actually get into and travel around our system, and then wrap things up with exactly how we measure their safety. So let's just kick things off with a fundamental question. It's actually one you've probably wondered about before. When you swallow a pill for a headache, how does it actually know where your head is? How does it navigate that insane highway of your circulatory system to find the exact source of your pain? Well, spoiler alert, it doesn't. And that brings us right to the fundamental science of pharmacology. You see, the pill is entirely at the mercy of a two-sided coin. On one side, we have pharmacokinetics, or PK. This is basically what your body does to the drug, how it processes it, and ultimately tries to get rid of it. Then, on the flip side, there's pharmacodynamics, or PD. That's what the drug does to your body, how it binds to your cells to create a response. So it's this continuous, intense push and pull.
But before this epic microscopic tug-of-war can even begin, the medication actually has to get into your system.
And how it gets in completely dictates the game. Think about it. If you swallow a pill, it faces a massive border checkpoint in the liver, known as first-pass metabolism. Honestly, it's like the liver is a strict bouncer, heavily reducing how much active drug actually makes it through the doors. But an IV injection, that bypasses the bouncer entirely. It gives you 100% instant bioavailability. And of course, we also have topical patches or asthma inhalers that use your skin or lungs for super rapid absorption. Okay, so let's move into Act 1 of this whole process and look at the body's role. Imagine your body as this highly complex, bustling chemical sorting facility. Pharmacokinetics is totally driven by 4 sequential steps. We call them ADME: absorption, distribution, metabolism, and excretion. These 4 steps dictate the exact time course of the drug's concentration while it's inside you. If you look at this central blue circle here, that's the drug in your blood plasma, acting as the main hub. Absorption, over in green, is what pushes the drug into the plasma. Distribution, in yellow, is this reversible transfer where the drug goes out to explore your tissues and organs. But meanwhile, your body goes on the defensive. Metabolism, that's the red box, chemically alters the drug to make it water-soluble, so that the blue box, excretion, can just flush it right out through your kidneys. Now, to manage this wild dynamic flow, clinicians rely on 4 mathematical pillars. First, bioavailability tells us the fraction of the drug that actually makes it into your systemic circulation unchanged. Then, volume of distribution helps estimate the initial loading dose by showing how extensively a drug spreads into your tissues versus just staying in your blood. Clearance tells us the volume of plasma cleared of the drug over time, which is totally essential for figuring out a maintenance dose. And finally, half-life, the time it takes for the drug's concentration to drop by 50%. This is exactly why your doctor tells you to take your ibuprofen every 6 hours. Together, these pillars help doctors calculate the perfect dose to keep you at a steady therapeutic state. But here's where it gets really interesting. Check out the stark contrast in how our bodies eliminate these chemicals. On the left, we've got first-order kinetics. Most drugs behave exactly like this, clearing out exponentially by a constant fraction over time. It gives us that nice swooping curve. But look over on the right at zero-order kinetics. If you overdo it on substances like alcohol or aspirin, your body's enzyme systems become completely saturated. They literally max out. So the drug just clears at a constant amount, creating this strict linear decline. All right, let's flip the coin to Act 2. We're zooming way down to the cellular level now to see exactly what the drug is up to. The best way to think about a drug interacting with a cell's receptor is like a key fitting into a biological lock. An agonist is basically a master key. It binds to the receptor, turns the lock completely, and produces a full biological response. Then you have a partial agonist. That's a key that fits, sure, but it only turns the lock halfway, giving you a submaximal response. And an antagonist? Well, that's like a broken key stuck in the lock. It fits perfectly into the receptor, but it doesn't do anything. It has no intrinsic activity, it just physically blocks any other keys from getting inside. And physically, these biological locks sit right across our cell membranes. On the far left here, ligand-gated ion channels act incredibly fast, like in mere milliseconds. Moving over, G-protein-coupled receptors span the membranes 7 times and work in seconds. Enzyme-linked receptors, like the ones that handle insulin, usually take minutes. And finally, on the far right, intracellular receptors. These are the slowpokes of the group, sometimes taking hours because the drug literally has to penetrate the cell nucleus to alter your DNA's transcription. It's wild. So with all this going on, how do we actually measure who is winning this epic microscopic tug of war so we can safely treat a patient? We use what are called log-dose response curves. If you look closely at the blue line compared to the green line, you'll see the blue line is shifted to the left. That means you need less of that drug to get a response. That is potency right there. Drug A is simply stronger than drug B. Now look at the red line, drug C. Notice how it just stops halfway up? Even at the absolute maximum dose, it will never reach that 100% response. That demonstrates efficacy, or the maximum physiological effect that's achievable. Drug C is a partial agonist. It just can't push the system to the absolute limit. All of this incredible science, the absorption rates, the half-lives, the cellular locks and keys, it all culminates in one vital calculation: the therapeutic index. This is the ultimate measure of a drug's safety margin. It compares the dose that is lethal in 50% of the population to the dose that is actually therapeutically effective in 50% of the population. Now, what does that actually mean for us as patients? Well, a drug with a high therapeutic index, like penicillin, gives you a beautifully wide, safe margin for error. The gap between an effective dose and a dangerous dose is huge. But a low therapeutic index, which you'll find in drugs like digoxin for the heart or warfarin for blood thinning, means that margin is incredibly tight. The chemical negotiation there is risky, and it requires careful, constant dose monitoring by your doctor to ensure the drug doesn't cross the line from therapeutic straight into toxic. As we wrap up this explainer, I want to leave you with one final thought. We've explored this amazingly dynamic, microscopic battleground of pharmacokinetics and pharmacodynamics. You now know it's not magic. It's a highly precise, calculated chemical negotiation. So the next time you swallow a simple headache pill, are you just going to see a piece of medicine? Or will you picture the incredible biochemical battle of absorption, distribution, locks, keys, and safety margins happening right inside of you? Keep learning, stay curious, and thanks for exploring this with me.